in cancer patients, diagnostic testing is the whole axis of which diagnosis is made. So a lot of times it tells you where the primary tumor is, it tells you how far the cancer is spread, to what extent it is spread, whether it's made it into the lymph nodes, and it tells you the places that it hasn't gone. It tells you the places that are free of disease. And all of these have to be taken into consideration when you determine what method and means you're going to do to treat the cancer. Before any type of decision can be made as far as treatment, you have to do staging. Colorectal cancer oftentimes goes to the liver in its metastatic process. MRI is an incredible tool for determining whether or not the patient has metastatic disease in their liver. All patients with colorectal cancer need to go through yearly screenings with MRI of the liver to make sure they don't have small metastatic lesions. They need to remember it's the small lesion that's the easiest to treat. So the earlier we can find it, the faster we can knock it out. PET imaging is a modality in which we inject a radio-labeled glucose into the body. We give it time to distribute, and then we image the patient. We know that glucose is used in the body on a normal basis every day. We know that the liver, the brain, the heart, some of the colon, sometimes small bowel, uses more glucose because of the metabolic processes going on within them. But also we know that some cancers utilize increased glucose in their replication. And we utilize that knowledge to help locate and target those tumors. So we image the patient and we know where the areas that should be hypermetabolic are, but then we look for areas that are hypermetabolic that shouldn't be there. And what that shows us oftentimes is what's known as a tandem or a second lesion. They see the primary lesion during colonoscopy and it's known. So we know that's there, it's hypermetabolic, and we're aware of that. But what we want to do then is look at the area adjacent to that, more cephalad, more inferior, and see if there's a second lesion which doesn't have any irregularity in the mucosa, which wasn't seen at colonoscopy but is still there. Because if that second lesion is there, it's called an occult lesion. It's not seen any other way. We can tell the surgeon you need to take out the primary lesion and you need to go a little more distant to get that second lesion. Oftentimes, these second lesions, when they go undiagnosed, end up as a recurrence at the surgery site.